Hi, everyone. How's everybody? Welcome to Skin School. I'm Dr. Barbara Sturm, and today I'm here with Dr. Hugo Verhoeven, who is a very, very good friend of mine. He helped me with Pepper and IVF. He is a doctor for endocrinology and reproductive medicine. He started something called endocrinological cosmetics. So he's super, super knowledgeable. He's traveling the world. He's just like everywhere doing conventions. You know, it's hard to find someone who knows about hormones. It's like, when you go to medical school, you learn everything, but you need to be a total expert in order to help people. And Hugo, I sent so many patients to you. I mean, like from everywhere, people calling him up, and because he's one of the experts, and that's why I want to share him with you, because there's so much to learn, because we're going through so many problems, where it could be like, becoming a teenager, hormones kick in, then we go in a contraception pill, then our skin is becoming better, then we decide, oh, let's not take the pill anymore, then all of a sudden we get acne, then we become 40, we get into perimenopause, then we're 50, we get into menopause. What's going on? What do we need to do? Why am I feeling like this? And there are just so few experts, because it's one thing to define, oh, this is what I have, but what do I actually do? How dangerous are the treatments? How good are the treatments? How long do I have to take them? How long do I have to go through this? And when it comes to skin, and Hugo, maybe I talk about skin quickly before we dive into all the hormones, but when it comes to our skin, there are like things happening because of estrogen is going down, and also the balance between testosterone, estrogen, progesterone is in this balance, is off. And then what we see is that, our collagen production goes down massively, our skin barrier becomes weakened, and, something happens which is called transepidermal water loss, which is that hydration leaves the skin, which makes us age, and we get the wrinkles and the sagginess. And wound healing becomes worse. We have not the microcirculation in our periphery that much that we get like healing factors in. So we have to supply a lot from the outside and from the inside. So with the products I created, and they're all surrounded about anti-inflammation, that's one thing. But another thing which is so important for menopause is hydration, is telomerase activation, is something called exosomes, bringing healing, repair molecules into our skin. And when we look at hydration, I always compare grapes and raisins. If we have these grapes, which are super hydrated skin cells, it has all these osmosis channels, it has makes juicy, beautiful skin with strong skin barrier function where water cannot leave the skin. So we make a good skin out of our grapes. Whereas when we have super dry skin and raisins, and these raisins don't have these osmosis channels, then our skin becomes indented and we have like wrinkles. The skin barrier becomes weaker. That's why we have something called transepidermal water loss. And all of these things make us age, make us saggy, make our collagen go down. So we have to improve our skin by, number one, using our super anti-aging serum. The super anti-aging serum is mandatory, not just to bring hydration into the skin, but also something called glutathione, which is one of the most powerful antioxidants to catch free radicals, which we are exposed more when we age. Also telomerase activator purslane, super important to keep cells divided and keep cells alive. Then we have to bring in vitamin C, vitamin B, also to catch free radicals, but also even out the skin tone, making sure our skin produces collagen, and something called exosomatic. I want you to use the exosomatic line, especially when you get into menopause. Exosomes are little particles which make the communication between the cells better, but also infuse heal and repair molecules into your skin. And that's important to upgrade your skin, restructure your skin. Skin has this like beautiful matrix, which with age goes all over the place. Normally soldiers are like walking in like very, very organized. And when we age, they're all over the place. And this matrix we have to keep organized. And that's why we need all those beautiful ingredients in those skincare products to add from the outside. That's number one. Number two is supplementing like our super anti-aging supplement with telomerase activators, inner hydration, the best and most powerful antioxidants. These are like things we can support on a very cutting edge level to help with, you know, the signs of aging and also what's caused from menopausal symptoms. And who, you know, I could talk hours, but, you know, we want to actually talk to you. And maybe you can explain to us a little bit, why do we have these hormonal changes? What are the symptoms? How can we see what's, you know, happening to us? Which doctor should we go to? Because I also know some people think they're crazy and all of a sudden they go to a psychologist and they give them some antidepressants or all kinds of medication, even though it's only menopause.
Thank you, Barbara. It's always so nice what you're saying about me. And it was really, of course, a pleasure to having you such a nice patient and that you're referring so many patients to me. We have been quite successful. You asked me to give an overview of what hormones can do for the perimenopause and the menopause. We are not only going to concentrate on the skin, because the skin is just a target organs for the hormones, but it's part of a complete hormonal system. So we are going to talk today a little bit on something called cosmetic endocrinology. What do we understand with cosmetic endocrinology? We should ask ourselves the question, what can hormones we all want? We want to feel good and we want to look good. And everybody knows if you look good, you feel good. And if you feel good, you look good. I always compare that with people waking up in the morning and they say, bah, I've had so much food last night, I do not feel good at all. You go to the mirror and you say, and bah, you're looking very bad this morning also. So that is what we want to do with our endocrinological parts of the treatment of endocrine problems, that we want to have the patient to feel happy, that he looks good, and that he feels good. So, but if we are talking about hormones, 99% of our listeners will not know what hormones are. So let's make it very easy. Hormones are chemicals, of course. They are produced in the endocrine glands, let's say in the thyroid gland, or in the ovary, or in the surrenal glands. And they are transported through the bloodstream to another part in the body where they deliver a chemical message. So if we say we go to different organs, that means we are not just talking about the ovary or the prostate. Very important are the skin and the muscles. We shouldn't forget that those two organs are full of receptors for all kinds of hormones. Like, we'll talk about that later, in the vagina and also in the urinary tract, there are so many receptors for estrogens, but also for testosterone. And that's what the hormones need. They cannot attach to an organ if there's not a receptor. So the more receptor in the skin for male hormones, the more the people will react on the skin. If you give them too much, they'll have acne or hair growth. So the hormones are binding to this receptor and they will stimulate or, and that's important, inhibit them. So that is what hormones are. It are just molecules who connect one gland with another part of our body. So we are talking now today, especially on the menopause, but that's not true. If the patients are in their menopause, the train is gone. That means if the skin is completely destroyed, if she has no more hair, then it's very difficult to restore that with the endocrinological knife. Then you need to go to the plastic surgeons. So it's important to understand that we have, the women have in their life 3 periods. The first one is called the pre-menopause. And that is the time between a woman's first periods and the onset of the perimenopause. The perimenopause is the transition phase into the menopause, making the end of the reproductive years. And it's very important to understand that women start their perimenopause not at the age of 40. They can start with it at the age of 30 or in their 20s or even under 20. So in that period of time, the body starts to look for changes. And then if the periods are over for 12 months, the classical school medicine says, then you are in the menopause once you have gone through 12 months without a menstrual period. We must concentrate on the perimenopause. So that is from the moment the patient says, oh, there's something changing in my life. I feel completely different. I have sensations that I'm not used to. And so what are we talking about here? So I just need, okay. So what are the symptoms that the patients at the beginning of the perimenopause, what are the changes she feels or sees? And we're going to go on that in detail later. Number 1 are the irregular periods. So the patient has anymore every month bleeding, she has irregular shedding. That is the first sign that the hormonal balance in the body is anymore stable. Number 1. Number 2 are hot flushes, sleep disorders. They do not interest us as endocrinologists, not that much, but for the patients, they are very, very unpleasant, especially the hot flushes during the night where the patients say 5 times a night, I need to go into the bathroom, change everything. I cannot do this anymore. Then we have the mood changes. Patients are getting depressed. Some are maniac depressive. Others do not see sense in their life anymore. Others are getting more aggressive. So they are different. Then the next very interesting thing for you, Barbara, that is the vaginal and the bladder problems. So vaginal dryness is one of the main problems of women going into their perimenopause or in the menopause. And we just concentrate on the vagina, but that's not correct. Because also the bladder, the complete urinary tract, so the ureter, the bladder, the urethra, and the vagina have tons of receptors for estrogen, a little bit of progesterone, but also testosterone. And the reason why women are coming to see you because of vaginal dryness or all the time bladder infections, what is very disturbing for them, It's just that the receptors do not react anymore on the hormones because the hormones are not there anymore. So that is something what we can treat very nicely. And remember, hot flushes will disappear from alone. Bladder infections and dryness never. If you don't do anything for the patient for the rest of her life, she will be very unhappy with you. And that's easy to treat. So the next thing is, that's not the topic today, the decreasing fertility. Of course, if the patient have no more or less ovulations, if the AMH, the anti-Muller hormone, is going up, the ovary is slowly giving up. That means no good eggs anymore, no ovulation anymore, and no fertilization anymore. That is evidence. So normally, so at the age of 34, 35, 36, it's more difficult for the patients to get pregnant on the romantic way. Exceptions are there, you, Barbara, and so many others. So my hobby is a little bit to have the patient between 41 and 44, 45 to do everything to have them pregnant with their own eggs. We are not talking about oocytonation. That's easy, that everybody can. But a patient between 40 and 45 getting pregnant, that is sometimes a little bit tricky, and that is always a challenge for us. So then we have, of course, that is also one of your topics, Barbara, the changes in sexual function. The patients will come to see you and say, you can put in front of me Richard Gere or whatever. I'm not interested. And if I convince myself to go on, it hurts and it's itchy and I do not have orgasms anymore. You need to do something about that. Why is that? Again, because the receptors are empty. The receptors for the male hormones. So male hormones are the absolute quality hormone of the aging woman. Yeah. So I have in Düsseldorf so many patients who I'm treating with male hormones just because they say, my sex life is nothing. Give them male hormones. And they say, doctor, you are the greatest. Then we come to the next very important thing, that is the loss of bone. Osteoporosis is going to be, in the next year, the most challenging disease for the insurance companies. They're dying at the age of 90. And if we don't care then about their bones, another thing, part of this is, of course, the loss of bone, but then we have, of course, also now the skin. So, as I said before, the skin is in the 3 layers of the skin, full of receptors for all kinds of hormones. You, Barbara, are treating the patient from the outside. Yeah, you're putting on the skin different substances to make the skin more healthy. We go via the blood and the lymph fluids. We come from under the skin. And very important is, you know that, why do men have less wrinkles and less cellulitis as women? Because the collagen layer is thicker. That is testosterone. So if you put on the skin from the inside and the outside testosterone, the collagen layer will get thicker. And I have so many models at the age of 18 till 23 who came to me because they want to have a prophylactic treatment of their regions where they are afraid to get cellulites. Everybody knows where that is. Well, it's controversial. Many papers say, how can you give to a woman of 18 a male hormone? Well, look at the athletes. they have from alone higher testosterone. They have no cellulites. They have no wrinkles in their face at a young age. That's because they produce themselves so much testosterone. So that is a little bit an overview, and I have a look whether I forgot now something. So we had hot flushes, irregular bleeding, vaginal dryness, chills. Oh, also chills are very, we forgot only one thing, the weights. That is also in the perimenopause, and we can do on that a session of 3 hours. Why are women gaining weight? Let's say it's a combination of lifestyle, genetics, and hormones. If you are not going to the gym anymore, if you have the genetics that all the women in your family were thick and fat, and if then the hormones go down, and then the weight gain will be so significant, well, that is now one of the treatment possibilities for semaglutides, so the Ozempic or the Mounjaro. So the weight gain or the weight changes, I had patients who lost shortly before the menopause tremendously. They lost weight for reasons that we don't know. So that is then a problem for internal medicine. There we are not going to say, oh, you lost 20 kilos. No, I'm going to give you, no. Why did you lose that 20 kilos? Maybe there is a tumor behind that. So that was a long introduction. And I think now, Barbara, you can select those items that you want to know. And then
I think what everybody wants to know, Hugo, what everybody wants to know is how to treat it. So what can we do to prevent from getting these symptoms, or once we have the symptoms, what do we have to do? How dangerous is it? How do we start? Is it for everybody the same? How does it vary? Because there's a lot of fear out there, why we treat, these issues a certain way.
Now, that is, of course, the most difficult question you can ask me. You ask me now, how do you repair a car? What car are we talking about? What model and everything? So if you cannot treat, let's say, hot flushes the same way as osteoporosis, that is evident. Osteoporosis, you're going to treat with, how do you treat osteoporosis? With magnesium, calcium, vitamin D3, sun, exercise, and estrogens. So you see, it's not only if you give a woman just estrogens and she's sitting in the dark all the time, she will develop osteoporosis. So it's always a combined concept. That means every patient coming to us presents her problems. And we decide then what we, from the endocrinological side, can do for them. That's different of what you are doing. So you cannot treat with your creams, for instance, osteoporosis. That's not working. But for the skin, I think you are so important as the plastic surgeons. And we have the endocrinological knife. The plastic surgeons has the real knife. And it's always the question, of course, what if the patient comes to us? What are the symptoms she has? And what are the symptoms she doesn't have, but we are afraid of? Yeah? So let's say a patient comes with irregular bleeding. We know, of course, immediately, that will not take long till she's coming with hot flushes, with skin problems and everything. So it is important to think about that, what the patient doesn't have. Yeah. I have patients who came to me at the age of 40, and I said, they said, I have nothing, I do not want, I have nothing at all. If you then tell her, yes, but be careful, osteoporosis and vaginal dryness will come soon. Don't you want to do anything about that? So that is the most important thing. What are the patients presenting to you? And what is she not presenting to you, but she will present that in 10 years, and that we want to avoid. So we are endocrinologists, so we think that hormones are the key factor in our life. That's very evident. So for all symptoms, we are trying to find the right combination to restore the original hormonal balance between the female hormones, the male hormones, like they were at the age of 20, 30. We are not talking today about your preferred topic about growth hormone or other anabolics. So let's just concentrate today on the estrogens, progesterone, and testosterone. Most of the symptoms in the menopause are because lack of estrogens. Very evident. Hot flushes, sleep disorders, osteoporosis, and so on. So that is our main thing. And nothing works without a blood sample. Yet, some patients say, I have nothing, and the blood is looking very bad. Estrogens are very low. What are you going to do? The patient said, I heard about HRT. I don't want that. Well, then you must say to the patient, you have no symptoms. And that's what I'm afraid of is not existing. We do not do anything. Other patients come and say, I heard from my friend and another friend and another friend that we should absolutely do something against the future. Okay, what? I'm exercising, I'm on a diet, I'm spending hundreds of dollars every month, and then it's always the problem. What do? We give, of course, estrogens, we give progesterone, we give testosterone, whether we do it as transdermal with a patch or a cream, or whether we do it orally.
You're breaking up in between, Hugo. You're breaking up.
Okay.
So whether you do it orally, like taking hormones as a pill, there are lots of people who say, you know, they're afraid to taking hormones as a pill. There are a lot of studies out from older ages, right?
Yeah.
I mean, like from long time ago.
And the problem is, Barbara, if you give 3 or 4 hormones as transdermally, the patient is getting sick of that. She puts estrogen there, progesterone there, testosterone on her behind and here. She says, I don't want that. So it's always like you are doing yourself, if I may say that.
Yes, but all my secrets. I don't have secrets. So I take hormones as a pill and it helps me super, super well.
Yeah. And allow me to say that you're a difficult patient, huh? To convince you.
I'm not a difficult patient. How can you say that?
But it is true. So
I was one of your patients. You got pregnant at 42. So Pepper is Hugo's responsibility. We did IVF. Well, Hugo did IVF.
But you know what I mean? Accepting that you're coming into a stage where the ovum is going to extinguish very soon. It's very difficult for the patients. And to accept to taking hormones, you know, from hormones you get cancer and everything. So that is difficult. But in you, we gave you transdermally the testosterone and progesterone and estradiol we gave you as a pill, as a tablet, It's not contraceptive, you know, they are bioidentical hormones, but not contraceptive, because the bioidentical estrogen is not contraceptive, it's not blocking the ovulation. Yeah. So many patients say, I do not want to take the pill. Okay, then fine. Then give her a combination of the same hormones, not as a pill, and then she will be happy. Yeah. So it's absolutely not true that you get cancer from the contraceptive pill. That is, yeah, maybe before, but the combination of the contraceptive pills now are safe. The progesterone of the 4th generation and estradiol, yeah. Question is, of course,
I also have
whether
to say, I find it so hard to not sleep. You know, if you have insomnia, if you have the hot and cold flashes, if you're brain fog, there's so many symptoms I don't want to have. So I'd rather also take the hormones, and it made it better for me, like in between days. So that is such an improvement, and you have the estrogen in your body, and it's good for your bones, it's good for your skin, it's good for so many things. I believe it's better to take something or use a cream, or that there are some contraindications though, Hugo. If someone had breast cancer before, they definitely don't want to go on hormones, especially when the cancer was hormonally induced. So what is your proposal then with anyone who had, like, you know, a problem before and cannot go on hormones?
So the patients we were talking about now are, of course, patients who are not at risk. If a patient comes to see you and had already 5 strokes or 2 heart attacks, you are not going to give her estrogens. But you remember, we have still phytoestrogens. So that's like genistein, that is dichain, red clover, soy products, who are not stimulating the alpha receptor. The alpha receptor is the one who induces cancer, you know that. So, of course, if a patient has a difficult history, then most of the anti-aging doctor will say, I stop. The risk is too high, Barbara. So I'm an old man now. I'm a very experienced guy. I want my treatment to be effective, that the patient can pay it. And of course, I take the lawyers out of my office. I do not want a patient to treat with growth hormone if he had, for instance, prostate cancer. I know there are doctors who just give him prostate cancer growth hormone, not with me. I send them to the professors at the university if they get sued. Yeah. So that is always, but 95% of the population that is listening to you now is not in the high risk group. And the 5% send them to experienced people who know what they are doing and say, okay, you had breast cancer, you had everything done, it's more than 10 years ago, let's try a little bit, but you're always at risk.
So anything you would do in preparation, can we do anything with our diet, with anything, you know, you said exercise, you did go in the sun, you said, you know, what's your diet? What are the most important things we can do without medical help to improve our situation?
There are 4 important, how shall I say, things supporting anti-aging. Number 1 is exercising. Yeah. Mm-hmm. Number 2 is, what are you eating and what and when? You know all that, huh? Mm-hmm. Number 3 is the or shall I say, the mental condition. So I love in the patient Pilates and meditation and everything. And number 4 are the hormones. So if you give a runner hormones and he stops running, he will not be happy with you. It's always the combination. So if you say no hormones, well, then we have only your products, mental health, training, and lifestyle. What are you eating? When are you eating? What products are you taking to you? That's the only possibility. So we used to have, now anymore, always a panel of 3 people. That was so 10, 15 years ago, in the time that the medical system in Germany was still a little bit more attractive for the doctors. But we had, in German, we call it Ernährungsspezialisten. So we had a woman with us who was very keen to find out exactly what are we eating, why are some fats not good and everything. So she was sitting with us, and a psychosomatic doctor, and then me,
Yeah.
and we put the patients together. But most of the patients say to me, we just want you, we want hormones points. You know that.
Hugo, another question. Once we take the hormones, how long do we have to take them? Do we have, and what do we do regarding screenings? How often are we going screenings? Do we do blood tests? What do we have to measure? Like,
first question, how long are you taking the hormones? That is depending again what you're treating. Remember, we were talking about bladder infection, vaginal dryness. That is like putting lipstick on your lips. If you don't put lipstick anymore, that will be different. So in those cases, you must probably treat the vagina with local estrogen for the rest of their life. And the patients will do that, believe me, because they know what are the changes, and local estrogens are not going in the bloodstream. They are staying via the lymphatic system in the urinary system. So you can give local vaginal estrogens also in patients with receptor positive breast cancer. So
that's good to know.
Osteoporosis, lifetime. You will not be able to, when the patient is developing osteoporosis, that will be lifetime. Other things are, of course, the hot flushes. There are patients who stopped their treatments and there were no hot flushes anymore. So that is worth to try it. The irregular bleedings are gone anyway, yeah. But then the sleeping problems, the mood changes, again, the same problem, The patients...
So we keep taking the pills forever.
What?
We keep taking the pills.
Yeah, from puberty till death. That is my opinion. But of course, different hormones. But it is an estrogen and a progesterone. And what kind of estrogen and progesterone, that is changing during lifetime. But the combination of those two is puberty till death, in my opinion.
So, Hugo, not everybody has you in their life. They can find you in Düsseldorf. I heard that you're not doing like phone consultations anymore, or Zoom consultations. Maybe you change your mind for us. But what a woman who's listening in now, what should she ask her doctor to look at when she looks at hormone? And there's another hormone we haven't talked about, DHEA. Is this something you recommend people to take? How many milligram? Or obviously that depends also on your lab work, no?
Yeah. That's all a little bit different in what part of the world you're working. And I did a lot, I still do a lot in Asia. And in Dubai, for instance, there the anti-aging, like in Korea, for instance, those people are crazy about looking good at the age of 75, and they do everything. So they go to their doctor and they find a doctor who will say, we do a complete blood check. We treat you with everything what I can take the responsibility for it. It's a little bit different in the United States. In the States, I have also here in Los Angeles the problem that I sent many many patients that I did treat already, and I said, go to, I'm not going to say the name of the universities, and they say, no, that's no reason for that blood check, that's not necessary. And if they make it so expensive that the patients say, no. So that is another opinion. In my opinion, it's always what are the patients saying you, what is the blood work, and compare and say the solution will be that and that, and then the patient can say, I want it or I don't want it. So how long? Mainly for most of the symptoms, lifetime. What was the second part of your question?
The AGA.
Yeah. Okay. I compare in Germany at least, DHEA is the Trabi, that's the car from the German Democratic Republic. Yeah. And testosterone is the
Huh? And testosterone is the Ferrari. Okay, so you think you can skip the DHEA?
No. So that's depending of what the patient wants. I say, DHEA is a surrenal gland male hormone. It is produced in the surrenal glands, and in women, it's converted to 80–90% into testosterone. It may not. DHEA is for women always a good male hormone for the beginning, and I can assure you that I had sopran singers who had with 10 milligrams of DHEA were going from sopran till alt. So the voice was from very high to quite low. I had women who had with 10 milligrams of DHEA a clitoris enlargement, acne, hair loss, aggressivity, yeah, and I have many others where it didn't work at all. So for the beginning, it's fine. Here in the US, I always say, if you go here to Walgreens and you ask for DHEA, they will say, sir, that wall, and that wall. In Europe, not. In Europe, they will say DHEA, melatonin, that's all. It's not true. I like DHEA. I always, well, in women, in men, it doesn't bring that much. With one exception, it makes quite euphoric. So on time, there was 20 years ago, DHEA, the happy maker. And indeed, if you give that to the aging males, give them DHEA, it's different. There, the male hormones are very important. Always the lowest dosage. Do not do like the US, starting with 25. I start with 5 milligrams. You know the company Vita Basics, you know that company. They have 5, 10, 15, 20 and everything. Start with 5 milligrams a day and see what happens. You can always go higher, but if you start too high and the patient has bad skin, she will not come back to you because you're a bad doctor. Always, always start low.
Hugo has a lot of experience, we can tell, right? So DHEA would be something for perimenopause, maybe, right? Already.
Yeah.
Okay. So we have someone who wants to dial in and ask a question.
Yeah, I think Caroline is on the line. Caroline, do you want to just turn on your camera and go ahead and ask your question?
Hi, Caroline.
Sure. Hi there. I'm Caroline from England. Hello.
London.
The question I had is I'm just starting with perimenopause, and I've been taking a number of vitamins and minerals, and I just wonder what are the most important vitamins and minerals to take at this stage?
Okay. That is also, again, a very difficult question, because people will say all vitamins and are bringing nothing. Others are crazy about that. So all the vitamins that I think are important are vitamins who treat the symptoms of the menopause, like calcium, magnesium, vitamin D3, vitamin B12. Yeah. But if you want to take coenzyme, I think 10, yeah, selene, nickel, there are so many things. In Vienna, they say everything brings something. They give you a cocktail of 30, 40 products.
Yeah.
I do that myself. I go to Aldi and I buy the cheapest polyvitamin. We are not talking about pregnancy. That's you said you are at the beginning of your perimenopause? Really?
That's right. Yes, I'm 45, and I'm just beginning to get some symptoms. So at the moment, I'm on magnesium, B vitamins, vitamin D, and fish oils. And I seem to be running quite well on those. But I just wonder really if there's, you mentioned calcium. How important is calcium?
Calcium is very important for the bone. Without calcium, osteoporosis cannot be. So it's calcium, vitamin D3, or sun. Yeah.
Yeah.
Training, and of course, estrogens. But that is important in the field of endocrinology. That what today is the Bible is tomorrow the worst thing you can do.
Yeah.
Just a week ago on Medscape, there was a big report on fish oil. Fish oil used, everybody was taking fish oil from Japan and everything. No, they said it brings nothing. It brings nothing. So
Wow.
then we say, 5 years ago, it was the Bible. No, there's a new study. It brings nothing. And that is with most of the vitamins the case, with exception the one where the data are very convincing, like, for instance, vitamin D3, very important, very important. And all the rest.
So I was going to say that's super to know, because I'm taking vitamin D with K2, I believe, but I'm not certain it's D3. So that's really useful. I'll check on that.
Cholecalciferol is vitamin D3. That is the one that is in your skin under influence of the sun.
Yeah.
Yeah. If you are in London and you have in July no rain in London, you can reduce vitamin D3. But like in Sweden or in North Finland, they're taking huge amounts of vitamin D3, and they have in their houses artificial, they want the light as a substitute for the sun.
Yes.
They go, yeah.
Yeah.
But it's always, again, my advice. You are at the beginning of the perimenopause. You have no symptoms. It is my job to tell you, be careful. In the next 5 or 10 years, that and that and that could happen. Don't start with with treatments when you are suffering. Think about doing something prophylactic. Yeah, that's like Barbara's products. If the skin is completely looking like the face of Mick Jagger, then Barbara cannot do anything. So you must treat the skin before it's atrophic. And that is what we're trying to do with our patients, always prophylactic. Yeah. So I think I would advise you to have a blood check. Yeah.
Yeah.
To have a look at your hormones, have a DEXA scan, because osteoporosis, I'll do myself once a year a complete MRI PET scan. Think about your breast. Yeah. So even if the doctor says mammogram only at the age of 45, I think that's not good. Yeah. We're doing MRI or mammograms at a much younger age. I'm Belgian. Yeah. In Germany, they see differently. And here, I'm now in Los Angeles here. They see it again. I see here patients of 50. They said, only touching. I said, really? No ultrasound? No ultrasound. Well,
in the UK, I must admit it's very late. So I haven't been asked for a mammogram, and I'm 45. So I think I have to go privately for some of these things. It's just the case now.
Well, yes, that is another problem, of course. Huh? What is necessary? What does the patient want? And what is repaid? Yeah. So if I charge you for a mammogram £5,000, you will say, so that's in Asia the same problem. If they do not want to pay for something, they make it so expensive that they say to the patient, we pay 10%, but still the patient says, we don't want it. That's different here in the United States. Here the patients are paying everything. I'm wondering sometimes.
Yeah. So that there are some benefits of being in the UK in that way, I suppose, but everything just seems to be a bit later now. That process seems to be later and later for women. But yeah, so private's the way forward, I think, on these things.
I apologize for saying that, but the medical system in England is at the moment very problematic, especially also in the field of reproductive medicine. So test tube babies and everything, it's getting very difficult in the UK. So there are patients now coming from the UK to Belgium, or because they say in England, first of all, it's too expensive and they have no availability. They just say, no, we cannot do it. We have no doctors anymore. Yeah, you know, that's just the problem.
Yeah, absolutely. No, I do. And I just think privatization is coming to England, really. It just feels like it's going to soon be like America. But, you know, this is a good thing to get ahead, and some great advice. So thank you very much.
Thank you for coming on camera, and
it's really useful. I use your serum. It's brilliant, anti-aging. It's making a real difference. So thank you.
Yeah, it's great. Keep using that for sure. Keep using that, and maybe do the super anti-aging face cream with it. That's perfect.
Yeah, I do that already. Yeah, at night. So it's fantastic. Thank you.
and the night cream, amazing, especially also for, you know, menopausal transepidermal water loss. The night cream is fantastic because it locks the hydration in, especially throughout the night. It's perfect. And another thing I want to mention here is the V collection, the V wash and the V drops to keep, you know, our vulva in good shape. And especially when we use shower gel, or if we would use soap, you know, which is very alkaline, we need to really make sure that we keep the pH in this area really acidic. And that's why it's good to have like separate wash, separate, you know, hydration, whatever it is you need. You use the V wash as your, you know, cleanser, and then the V drops as an aftercare. But it's just like super nice.
This is these are your products. I'm not sure I know about them, these drops.
Yeah, these V, it's like we call it the vulva drops and the vulva wash. So as we look at our skin is slightly acidic, but especially in the genitals, the skin is super acidic. It's a super acidic milieu because we need like certain bacteria, especially the one bacteria, which also keeps the microbiome intact. And prevents from getting UTIs or candida or dryness, and that's why it's so important to keep the pH in the right level, and that's why we created a wash and the V drops as a hydrator, like almost like a yeah, it's like a hyaluronic serum, you know, especially after shaving, or I use it every day. It's amazing. It's a game changer, especially also in menopause.
Fantastic. Okay, I'll definitely look into that. Thank you.
Great.
Barbara,
Yes.
Barbara, may I ask you something?
Yes.
Yeah. What is your opinion about the facial scrub? I advise so many patients your scrub. I do it myself, but my
good.
dermatological friends, they say, you are crazy. You can do that once a month and not more. And I say, why? Because you get telangiectasia from that. Is that true? What do you think?
Oh, so first of all, it depends what type of scrub you're using. If it's harsh or if it's mild, you know, our scrub you can use twice a week. You won't get telangiectasia. But what we also do is having the enzyme cleanser. So if you want to be super mild for your exfoliation, you use the enzyme cleanser, which is basically just these two enzymes which break down the lipids and the proteins of the cells and gently take off dead skin cells. But I love the scrub too, because it also power hydrates your skin and is a mechanical exfoliation, which is also nice to stimulate, you know, the production of collagen. And you know, I personally love the scrub. Hugo, thank you so much. You're such a wonderful friend. I love you very much. Thank you for all your insights, your lecture. Yes, you did so well. Thank you for being here. And let's do this again soon. Maybe we do a class about reproductive medicine and freezing eggs, all the things we are also interested in, okay?
Yeah, it's finished. We can go on for half an hour if you want.
I know, we could go on forever. Thank you, Hugo. Thank you, everybody, for watching. And I see you guys soon. Big kiss.
Thank you.
Bye.
Bye.
Bye.